Metacarpal fractures. The good thing about metacarpal fractures is they're probably the easiest one to treat. So there are different sorts of metacarpal fractures, and I'm going to talk about each one differently because where a metacarpal is fractured will depend on how we manage that metacarpal fracture. So let's start at the head or the neck of the metacarpal fracture. These are the most common, especially in a boxer's fracture, which is a fracture to the fifth metacarpal neck. Now these are often treated conservatively because they are relatively stable. In fact, because of the amount of motion that you can get from your fifth metacarpal CMC joint, these are most often treated in a splint. Even if you get a little bit of volar angulation with a metacarpal fracture like this, it can be counteracted by the relative motion of the fifth metacarpal. So we don't need to operate on these every time. The things to look out for when it comes to metacarpal neck or metacarpal head fractures is definitely rotation. So if the person's fingers are rolling in under their other fingers or rolling out ulnally, then we need to try and make sure that they have some sort of operation or fixation, because this is difficult to correct, even with a thermoplastic buddy. So a metacarpal neck fracture often needs to just be splinted with the MCP joints at 70 degrees and the PIP joint and the DIP joint free. The more flexion you get of the MCP joint, the more stable the fracture becomes, because the base of the proximal phalanx basically pushes itself up against that metacarpal head, further stabilizing that position. So go for 70 degrees, but go for even more if the patient can, encouraging more and more flexion within the splint. Just like with proximal phalanx fractures, the interosseous muscles are the main deforming force for a metacarpal fracture. If we flex the MCP joint to 70 degrees, then we take away the efficiency of the interosseous muscles. And what this then does is this takes away the deforming force and adds to the stability of the fracture. It's really hard to get 70 degrees of MCP joint flexion in a swollen fifth metacarpal fracture. So always watch out for that. The more flexion you get, the better the result is going to be for the patient. Once you've got a good splint position, the rest is relatively easy. It's really important that you try and be mindful of the rotational deformity, maybe putting them into a thermoplastic buddy in order to hold the position. The other thing you want to try and do is make sure that they're moving actively, regularly, because there's a high tendency there for the extensor tendon to stick down over the fracture fragment site. Movement will also help to pump the fluid out of the hand. Generally, metacarpal fractures are healed within 3 weeks, so that splinting position only needs to be on all the time for the first 3 weeks. Even then, if the fracture fragment is stable, the patient can don and doff the splint for washing, for eating, for general things around the house. They don't have to have it on 100% of the time. The splint is much more important for their exercises than it is for anything else, because encouraging that fifth metacarpal, especially the fifth finger, to go into a further flexed position only helps the stability of that metacarpal fracture. And it's the same for all of your metacarpals, right the way across, from your index finger to your little finger. By 3 weeks though, if it was a stable fracture to begin with, or if that fracture has had surgery, you can really start to get them going out of the splint. Metacarpal shaft fractures are relatively stable. Metacarpal shaft fractures often happen from a punch or a twisting or a torsional injury. Where there's some rotational deformity, or you've got an oblique or a spiral type fracture, these often need surgical fixation because they're often associated with some sort of rotation or spinning of the fingers, meaning that they get in the way of each other. However, if it's relatively stable and the fingers aren't getting in the way of each other, these can be treated with a hand-based splint, holding the MCP joints at 70 degrees and leaving the PIP joint and the DIP joint free. You often don't have to include the wrist, especially if that fracture is stable. If it's a relatively unstable fracture, but it's not going to have surgery, you might then want to include the wrist in your early post-injury management. Otherwise, these sort of fractures heal very similarly to a metacarpal neck fracture, and the anatomy and the biomechanics of that joint are much the same. Try and ask yourself, is it stable or is it unstable? If it's unstable and can have surgery, then it's probably a good idea. If it's unstable and the person can't have surgery, then rather than make them a hand-based splint, it's probably a good idea to put them into some forearm-based splinting protection, at least for the first 3 weeks. Metacarpal base fractures. Well, these are interesting. They're also quite confusing because we think of the metacarpal as being a finger bone. But when it comes to the base of the metacarpal, it's actually much more of a wrist injury than anything else. These sort of fractures are quite difficult to pick up on. They're quite often intra-articular. They'll happen from a punch or a kick or something like that. So because they're intra-articular and because they're down at the base of the bone, often a CT is the best way to try and diagnose a base of metacarpal fracture. Because they're comminuted, they're difficult to treat surgically, and often they make up the attachments with other ligaments or important tendons that give the base of your metacarpal more stability. So they're painful for much longer, and their deforming forces are much different to that of metacarpal shaft and metacarpal neck fractures. In fact, if we think about the base of the fifth metacarpal, it's much different anatomically to the neck of the fifth metacarpal. At the base of the fifth metacarpal, you've got the attachment of your extensor carpi ulnaris and your flexor carpi ulnaris tendons. Now, in a normal, unaffected wrist, these two muscles hold on to the base of the metacarpal to try and make the base of your fifth metacarpal more stable. However, if your fracture involves the base of the fifth metacarpal, you don't really want them holding on too tight. In fact, you don't want the wrist to move much at all. But if the fingers were actually able to move, if the MCP joints were actually able to move, it doesn't really affect the base of a fifth metacarpal at all. So our splint for a base of metacarpal fracture is always a wrist splint. We treat these in a very similar way to how we would treat a carpal fracture. The base of the metacarpal heals really slowly. It probably takes at least 6 weeks of splinting, and then following a CT or an X-ray to try and check the union before you even bring them out of the splint. Now this is much different to metacarpal shaft fractures and metacarpal neck fractures which heal within 3 weeks. Always be mindful of the fact that a base of metacarpal fracture is going to elicit wrist pain. So all of our treatment focuses on strengthening and stabilising the wrist. Getting the person to squeeze putty or to do strengthening in that way for the fingers will only destabilise the base of the metacarpal. Following sound union, following an X-ray, following a CT, really try and work on isometric strengthening in the early days and isometric especially of your wrist stabilisers. Now it'll vary as to which wrist stabilisers you're focusing on depending on which base of fifth metacarpal you've broken. However, you want to stabilise the whole wrist. So don't start them too early on TheraBand or eccentric and concentric strengthening. This is only going to make them more painful. They're going to get more pain in the base of that metacarpal. And when that happens, it's difficult to turn that pain around because you've effectively destabilised part of their wrist. Make sure that you move them through each of these stages carefully, always asking the patient, have you got pain or haven't you got pain? I can't give you a week by week breakdown as to when that might be because we all heal differently and all fracture types are different. But what I can say is start off isometrically, move through very slowly into very light concentric and eccentric strengthening as their pain allows. And then once they're relatively pain-free, you can go for it with the free weights, with the lifting, all of those sort of things. So if you suspect a base of fifth metacarpal fracture or a base of metacarpal fracture, first thing you need to do, get a CT. An X-ray is not going to cut it. You need to treat them differently. These are wrist injuries, not finger injuries. You need to make sure that, again, at the 6 or 8 week mark, you get another CT to make sure that there is sound union. Once there's sound union, strengthen them isometrically and then crawl, walk and run. Slowly move them through your concentric and your eccentric strengthening programs.